This conference will now be recorded.
Okay, hi everybody. I want to thank you all for taking time out of your evening to be with us here on our presentation on meniscal preservation. I want to apologize for any potential background noise. My 9-year-old twin boys have taken over my computer, and I am hearing helicopters and screeching cars. So I hope nobody else hears that. I think there's a game playing in the background. So hopefully we're good. I think we are. I wanted to talk tonight about kind of an emerging part of orthopedics and sports medicine specifically. I'm one of the partners in reconstructive orthopedics. I'm a sports medicine specialist, and my focus is knee and shoulder surgery. And my real goal is to preserve joints and to prevent them from going on to the next real kind of phase of knee surgery, which is joint replacement surgery. So a trend that's really been growing over the last 3, maybe 5 years is something we call meniscal preservation. So I wanted to get into that tonight. I'm going to try to keep this fairly basic. I don't want to bore anybody or keep anybody's evening time away from family and other things they have to do. So these are really the objectives that we're going to go over tonight. I really just want to talk just about basics of what is the meniscus and how does it function. Give you an idea of what the symptoms and signs of a meniscus injury would be, which is, I think, really important. We're going to understand a little bit about what the historical treatments have been and what the new trends are, and then really get into just the outcomes and the difference that meniscus preservation can make. So without further ado, we'll get into it. So the meniscus is a C-shaped structure. There's 2 in each knee. And so if you look at the main picture that we're looking at with the red and the purple or blue structures being outlined, the lateral meniscus is on the outside of the knee, whereas the medial meniscus is on the inside of the knee. And what the meniscus looks like in a cross section is that picture that's represented above that has the 3 colors. And I'll get into what those colors represent in a second. But the meniscus has basically a C-shaped structure, and it is attached to the bone in 2 places called the roots. So if we look at the big picture with the blue and the red, the roots are the part of the meniscus that are towards the center of that diagram, and what they are is an attachment to the bone, and those are going to be discussed in more detail because that is really one of the focuses of meniscus preservation surgery. That's one of the key areas that we see damage that we can repair and make a big difference in. It's a flexible type of cartilage. Unfortunately, like everything else in life, as we get older, that flexibility starts to wane a little bit. Things get a little bit more brittle. They don't stretch and move like they did when we were, 14, 15. And we start to see tears for less than stellar reasons as we get older. They have a very poor blood supply. So if we look back up at this cross-section picture where the 3 colors are, to the far right, there's a line that represents a little blood vessel coming in. So that red line on the side is a blood vessel, and it punctures the fat part of that meniscus, which is what we call the red zone. That has a really good blood supply. Generally, things with a good blood supply can heal well, whereas things with a bad blood supply don't heal very well. So if we look as we get farther towards the center of the meniscus, it is then referred to as the white zone, and that is a really bad area for the meniscus to heal. Historically, that's why a lot of meniscus tears were not treated with a repair, because we found that because they didn't have a good blood supply, they didn't generate a healing response. And so we'll talk about the implications that has on our current thinking, but that's important for us to know because it's really forced most of our surgical decisions to be based around removing the damage instead of trying to restore it and repair it. And we're realizing now that some of the things that we thought about meniscus healing historically are not actually true anymore. And it has to do with some improvements in technology, some improvements in our ability to aid biology and get it to heal a little bit better. So those are things that are going to be important for us to talk about as we go through. But this is the basic of a meniscus. It really had me and 2 major roles. It acts to distribute stress from weight bearing. So when we walk, if you look at the diagram to the left with the meniscus, that meniscus, which is represented by that green structure, it it distributes our weight-bearing stress evenly across that joint, and it lets the body stand up to that stress of weight bearing, whether it be from simple walking or running, which creates a significant increase in stress, almost 6 times body weight. And the diagram to the right shows what happens without a meniscus. And people have heard this term bone on bone. Part of that refers to the fact that without a meniscus, the bones have less cushion and they have less ability to spread that weight bearing stress out. And we start to see a significant increase in the compression forces that the knee feels, and that starts to lead to a more rapid degradation of the joint. It does help with stability, and that's also important because what it does is it keeps the knee from shifting around or moving around too much, and that also helps to slow down any progression of damage or degeneration within the joint. Again, it relies on the attachments, and the reason it relies on the attachments is without the bone attachments to the meniscus, these what we call hoop stresses don't allow the meniscus to function in the ways that we just described. It can't distribute that stress evenly, and effectively somebody that has a tear of the meniscus, a big tear, greater than 25, 30%, or a root tear, which is again that critical attachment to the bone, those patients effectively act like they don't have a meniscus at all. And we'll talk about what that means in a little bit. So a lot of people come in and say, you know, I don't know what happened. My knee started hurting me 3 months ago. I don't really have any good stories to tell. Don't know why. You know, what could this be? Well, about 70% of meniscus tears are what we call degenerative. We see those in middle-aged patients with simple everyday activity, twisting, pivoting. You know, the most common mechanism that I describe to patients is, you know, you're squatting to get something under a low cabinet, and on your way up, you know, you twist to change direction, and that combination of a twist and a deep squat or a weight-bearing maneuver can catch the meniscus between the two bones, and it shears it, and you end up with a tear. 30% we see in a much younger population. One of the big groups of people that I treat in my practice are younger athletes, ACL injuries. There's a very high percentage of lateral or outside meniscus tears in ACL injuries, and so that's the other subpopulation, but it's a smaller population than the degenerative population. So the real focus is going to be on those two groups where we see a repairable meniscus tear pattern. Now, not all meniscus tears are repairable, and I'll get into those in just a bit. Common symptoms are sharp episodic pain. It's very uncommon for a meniscus to just be achy and sore. So, I always try to describe to patients, if you've just got achy soreness, it's less likely, we never have absolutes in medicine, but it's less likely to represent a meniscus tear versus something like arthritis where the joint's just inflamed, but all the structure is still intact. You're just losing some of that cushion in the cartilage. Meniscus tears are usually what we call mechanical and episodic. So you'll have an acute catchy pain, sharp pinchy pain when you go to twist or change direction. Again, the mechanisms that can cause it can actually exacerbate symptoms. So if you go to squat or twist, it usually causes a catch in the knee, and patients describe these giving way episodes at times. So those are in general what we've found meniscus tears to cause, and so that can be helpful if you're dealing with some of these symptoms and you're not sure what it is. That's what we've found. So the diagnosis and testing, it's unfortunate. I found that picture and I feel like I look 20 years older now. I have 9-year-old twins, I might have mentioned already, and it's a lot of gray in my beard. It's a shame, sad. Anyway, I think it's really important to have a physical exam by an orthopedic specialist, and I'm clearly biased in that regard, but early diagnosis is very critical in effective treatment. And one of the reasons is as we progress with the ability to repair a meniscus and to preserve a meniscus, we like to diagnose that early. Early meaning hopefully within weeks. Most people aren't coming in within days, but weeks. So if there's pain that's persistent 2-3 weeks and you're not trending better, generally there's something wrong and we should diagnose it. And the reason is the more you walk around on it, the more you continue to go through your normal activity, the more likely that you're going to damage other structures in that knee, or try to return to a likely you're going to damage or also progress the amount of damage in the tear. And so you can change a repairable tear into a non-repairable tear and that significantly changes the potential outcomes that we can have for joint preservation. And so I think it's really important to get an early diagnosis. A lot of what we can tell about meniscus tears can be told through a really good physical examination and a really good history. So just listening to our patients, I can almost tell 90% of the time what a patient has just by listening to them and watching where they describe their pain, and going over the symptoms they describe. The rest of that can be confirmed with a physical examination in most cases. X-rays are taken in the office as much to prove that there isn't anything significant there as anything. So a lot of patients ask, well, why do I need an X-ray? Not going to be able to see anything, and that's true. But we also want to prove that we can't see anything and make sure that you don't have something like arthritis or a bone lesion or a loose body in your joint, little things like that. So we don't want to see anything on an X-ray, and that's usually the case with an isolated meniscus tear. The real test to diagnose the meniscus tear and the pattern is an MRI, and that's really important. Once we've gotten enough suspicion through our history and our exam, the MRI is really the test that we need to get. Unfortunately, insurance companies want to see that we've gone through a conservative treatment plan. People have tried anti-inflammatories, physical therapy, and that's almost been a knee-jerk reaction with knee injuries, pardon the pun. But the unfortunate side is now that we're seeing these meniscus repair patterns come up more frequently and our technology's gotten better to be able to fix them, that delay in treatment could again mean the difference between a repairable option and a non-repairable option. So we are trying to be a little bit more aggressive about trying to get MRIs in some of these patients that we think may have a repairable pattern. But again, it's just been a little bit of a struggle with the insurance companies lagging behind with those trends a little bit. I know I keep talking about meniscus root tears. Those are really the big population that we're seeing. We can actually save a significant amount of trouble for patients down the line if we can repair. They can be really difficult to see even on an MRI, but if you look at these enough, there's certain patterns that we get to pick up on and we can tell. So this is just an example, different diagram of a meniscus. We're seeing the top edge of the shin bone. The one that they have pictured here is a lateral meniscus tear, which is indicated by that smaller bone on the leg called the fibula. And some of these tears look this way. This is what we call a radial tear. Radial tears are a little bit harder to fix technically because they get into that white zone, and part of the meniscus may not have a healing response. Even if we can stitch that together, it might not have the biology to be able to heal it back together. So those can be a little bit more tricky. But I just wanted to show you what a picture of a meniscus tear may look like. In this picture, the roots are designated by that darker tan portion where they come to the center of the bone and they attach. And again, if one of those popped off, that would be an example of what a root tear looks like. So I'm going to go to just a kind of a common diagram of different types of meniscus tears. So very commonly we see D, which is the radial tear that we just looked at. C here, called a bucket handle. We see that very commonly in younger athletes that have tears. This usually causes the knee to literally lock up, and that is a repairable pattern. They do really well. Down in E, we see an example of a root tear. And those, again, are a big option for us to be able to fix, and we want to fix those. F and D, these oblique tears and radial tears are very hard to fix. G is a horizontal tear. That's hard to see. You can't see it if you're looking from the top, but you can see it if you're looking from the side, and it's almost like a split in between the fibers, and that's actually very repairable now too with some of the newer technology that we have to be able to suture things together. So what we used to consider probably mostly irreparable meniscus tear patterns, about 50% of those, maybe 60% of those now are repairable options for us. So again, historically, we would favor non-operative treatment. We even though we're surgeons, about 90% of what we do is non-operative treatment and care. There's some really good studies that show that the non-operative, I should say the non-repairable meniscus tear patterns can be treated successfully in about 30% of people without surgery. So physical therapy, and what physical therapy is designed to do is help control excess motion, teach you how to manage compression forces in your knee, help you develop more hip and core strength, which can also dissipate some. Those things can do tremendous job at about 30% of people. Fortunately or unfortunately, I treat a lot of athletes, and I'm an athlete myself, so I don't like telling people to do I'm sorry, to not do things that they want to do. So I think it's very easy for a doctor to say, well, you're a runner, but you might have a meniscus tear, so stop running. Just give it up. You don't have to do that anymore. Well, to a runner, that's a death sentence, and we don't want to do that. So the relative rest and avoiding high impact activity, although I listed them here, they're things that in my practice I probably don't tell people as much just because of the nature of the people that I see. But there are reasonable recommendations to people who don't need to do those things or don't have demands that involve sports or high impact. Over-the-counter medications, ice, those can help. Honestly, just time. Time is one of the things that we see help people with meniscus tears the most. It's a very common mechanism. People that have that twisting injury, they come in 3 weeks later, say, hey, my knee's really hurting me. We clinically diagnose them with a probable meniscus tear. If it's a non-repairable pattern, we're going to continue to follow that. And usually by about 6 to 8 weeks, we'll know if that person's going to be okay, regardless of some of the other things that they might have done to help get better. The body does a very good job of settling things down without our help many times. Although, again, I am an advocate for therapy. So what happens if we don't treat a meniscus tear? I'm going to specifically talk here about root tears more than anything, because a root tear, beyond the other types of tears, has a much higher impact on a loss of normal meniscus function. And effectively, it can almost be considered like taking that meniscus out completely if you have a root tear. So it truly affects quality of life. It does not allow people to get back to higher impact activity, sports, twisting, pivoting, if you're active in the house, things like that. If you have a physical job, it's generally a very disabling thing. Because of that, you start to lose the cushioning effect in the knee. And what we found is that there's a much more rapid progression of the development of arthritis in the knee, which is where you lose the other types of cushioning cartilage in the knee. There's a much more rapid development of that in people who have a meniscus root tear. And some of these recent studies, these are all pretty recent studies, some of them have shown that about 30% of people with an untreated meniscal root tear can go on to develop the need for a total knee replacement in a very, very short period of time, 3 to 5 years, which is really significant. Here on the pictures here, I just have an x-ray of a total knee replacement on the right and a partial knee replacement on the left. But that's a really significant loss of function in a really quick time, and can lead to a really big surgery, like a knee replacement. And they do a great job, but if you're middle age, you don't want to jump into a knee replacement because they wear out and you're looking at another one. Average life expectancy right now for people is about 86, give or take. And so if you have a knee replacement at the age of 45, 50, you're looking at 1, if not 2 more surgeries down the line to redo those when they wear out. So our goal, my goal in sports medicine, is to try to prevent that from happening and to preserve the joint. So the surgical options, again, if we look at historically what was done, we would go in and they used to remove the whole meniscus. So my dad is one of my partners. I won't tell you how old he is, but he, in his early years of treating meniscus tears, they would make an incision and they would go in and remove the whole meniscus and thought it was no big deal. And clearly over time found that those patients went on to develop pretty rapid arthritis within 3 to 5, 10 years and developed a need for a knee replacement. So they quickly realized that that wasn't the right thing to do, and then went to partial removal. So they would just nibble out the damaged portions of the tear to get that mechanical clicking and popping to go away and some of that sharp, catchy pain. And we still do that for those repair patterns that we mentioned, but not all. When we do that, it's a very quick recovery. It's about a 15-minute surgery, 2 little poke holes in the front of the knee, and we go in and we just nibble out the damage. We try to remove the least amount we can to take care of those symptoms, and patients can get back to doing things pretty quickly. And there is a downside to that, again, loss of part of the cushioning effect, but beyond that, people do pretty well. The new trend is to try to repair these menisci. And so what we found is that the tear and the location determine that for us, and we talked about that a little bit. There are also patient factors that determine that. The major patient factors for prohibiting a repair are moderate to advanced arthritis. So if somebody already has arthritis in their knee, it really doesn't make a lot of sense for us to try to put them through really gaining them anything, but we're developed arthritis. So repair surgery because we're not really gaining them anything, arthritis. So, a moderate to advanced state, we don't want to do repair. Obesity has also been shown to be another factor that leads to poor outcomes. So we use a number called BMI, which is body mass index. It's a ratio of height to weight. And over 35 has been shown to correlate with poor outcomes of attempted repairs. And then age over 55. Age is a relative thing, whereas the other two are a little bit more hard line indications for not doing a repair. Age is more of a relative thing, because we do see patients who are 60, 65 for an unbelievably excellent condition, have perfect looking joints other than having a meniscus tear. And in those patients, I would still consider them a candidate for surgery. So recent studies have shown that a repair versus a removal can have a significant impact on the outcome. So if you look at the bottom here, root repairs show significant improvement in knee function. And we gauge that through these testing modalities and scoring systems where we can determine significant differences. And there's superior knee function in people that have a repair. 96% demonstrate good results. Repair patterns that the root repairs actually heal really well. Some of the other repair patterns may not heal as well because they can get into the blood supply problem, but all in all, somewhere between 70 to 90% success rates with a repair of the meniscus. 70 isn't a great number, but it's really based on the anatomy and the biology. The most important number is the bottom number here. In these studies that have recently come out, there's a 0% conversion rate to knee replacements. Whereas if we look back a couple slides, if we don't treat a root repair, within about 3 to 5 years, there's about a 30% conversion. And there's some other studies that go up as high as 50% conversion rate. And the farther out you get from that tear, the higher that number goes. So that's significant. I mean, effectively what this study and these studies that are coming out now are telling us is that if we can repair that meniscus and get it to heal, we can save patients from having to go on and have a knee replacement. So that's really exciting. And that's one of the reasons that, I've become pretty active in doing this. Again, there's that younger Dr. Bernardini there in the lower right. The surgery, I really think, has become something that absolutely has to be performed by a specialist. These are very, very technical procedures. They require a lot of experience, a lot of comfort doing really complex things arthroscopically. You cannot get to these easily in an open procedure. So if you had to make an incision, they're very, very difficult to get to. Most of the tears are in the back part of the knee, and that's really, really difficult to get to without being able to do special things arthroscopically. So I think a knee specialist who is adept at doing meniscus repairs is important. I think that question is really important to ask doctors. It's very confusing to patients whether or not they're going to have a repair or a removal. And a lot of times those words are interchanged even by physicians and medical professionals, and they shouldn't be, because it's really misleading as to what the outcome could be. So I think it's really important to be able to say to a doctor, how many of these do you do? What's your experience? Do you have people I can talk to? Are you comfortable doing these complex repair techniques that involve multiple I mean, there's about 4 different major types of repairs that we need to be able to do when we go in to do any meniscus repair. And I think it's really important to have all those tools in your bag and have all that equipment with you when you're there. Arthroscopic options are comparable to open in the front part of the knee, but not in the back, like we discussed. Complex techniques. The complex techniques that we use are really based in large part on the technology advancements we've had in the last, I'd say last 3 years, really. There's a specific device that's come out recently that lets us put stitches in a way that we couldn't put in before, and has really opened the door to a whole new type of repair system that we can use. The other thing that's really been a really important development in our ability to fix these and get them to heal a little bit better is something called PRP, which stands for platelet-rich plasma and stem cells. They're both in this category of biologic enhancements for repairs. And what we do with PRP is while you're sleeping under anesthesia, we take blood, we spin it down in a machine, and we concentrate these cells and growth factors that we then inject around and in the repair site. So after we do these, we dry everything out, we get all saline fluid out of your knee, which we use saline fluid out of your knee, which we inject things better during. But after the repair, then we inject this PRP or stem cells, which are less commonly used, but they both have a role. We won't get into that here. We inject that into and around the repair site, and what that's thought to do, and there's some studies that are trending towards this. It's such a new technology that we don't have great results on this yet, but there's studies that are starting to show that that actually can enhance that poor blood supply issue that the meniscus has and get these techniques to heal a little bit better. And so that's really important. So I think that the equipment and the PRP and stem cell use is really important. And I think it's important to talk to your physicians about that. I do think that if you go to see somebody and says, we need to go in and trim this meniscus out, no big deal. This is what we do for these. You're going to do great. You're going to be able to walk right away after. I think you get a second opinion. Not everybody has progressed with the meniscus preservation trend. And I think if you're somebody that feels strongly about preserving your joint, getting back to a higher level of function, and preventing the development of arthritis in the 3 to 5 year time span, then I think you should absolutely get a second opinion and make sure that this is truly not a repairable meniscus. And I think you should really do your research about finding somebody that is comfortable doing meniscus surgery, not just by going in and nibbling it out, which is what the vast majority of physicians have done for meniscus tears historically, but trying to find somebody that can actually do meniscus preservation surgery and is comfortable doing any kind of meniscus repair technique. So I hope, not too bad. I hope everybody enjoyed that. And if there are any questions, I'm happy to take those now. I may need Christina to read those to me.
I'm here. We don't have any typed questions, but I just want to say thank you again, Dr. Bernardini, for all that information.
Sure.
And like Dr. Bernardini said, we're going to go ahead and open it for questions now. You can feel free to go ahead and type them in the chat box, or if you want to go ahead and unmute yourself, if you feel more comfortable asking your question, please go ahead and do so. Let's just be mindful and only have one person speaking at a time.
Well, I know I could have done that good a job at clarifying everything. So somebody shoot me a question.
Can you hear me, Dr. Bernardini?
I got you.
What can you tell me about a ganglion cyst on the side of the knee as it relates to the torn meniscus?
So ganglion cysts are actually pretty common. They're much more common in the lateral or outside meniscus than they are in the medial meniscus. So basically, normal anatomy it keeps all the joint fluid, which is there to help kind of provide nutrients, start cartilage, and lubricate the joint a little bit. Normal anatomy would keep that fluid contained within the joint. And so there's a couple cases that we see where that fluid can escape and it can get into a place where it's not supposed to be. So lateral meniscus tears are very commonly these horizontal tears where there's a split in the meniscus, so that it literally splits through. So it allows that fluid to go from inside the joint to the outside of the joint, and it can escape outside of the joint. And that fluid's not meant to be there, so it doesn't really have anywhere to go. So it actually just forms this little encapsulation, and we call it a ganglion cyst. Those are common on the lateral side, although they can occur on the medial side. The other time that we can see fluid that's associated with meniscus tear is something called a Baker's cyst. Those are much more common on the medial side, and they happen in the back of the joint. And basically, similar thing, most Baker's cysts are associated with meniscus tears, and that fluid escapes through the tear, gets into the space where it's not meant to be, and it's almost like a one-way valve. The fluid can squeeze out, but it can't decompress back in, and it forms a collection of fluid. And sometimes people have symptoms from those, but usually they're just a symptom of the underlying meniscus tear.
Okay, thank you. You've been very informative. Thank you.
Sure. Thank you.
Is there anybody else tonight that had any questions? Give it a minute just in case somebody's typing something.
Sure.
Yeah, doctor, I believe that I have a ganglion cyst, and based on your lecture over the past 30 minutes, I think I'd like to set up an appointment for an assessment.
Sure.
So I'll
Christina,
go ahead and do that.
Can you help me with that?
I can do that through the portal if you'd like.
There's, sir, actually, you can visit our website.
The portal.
Okay.
Yep. Or you can, I was just going to say, or you could visit our website, and we have a link on our website for you to request an appointment online, and somebody will give you a call tomorrow morning and make that appointment for you, whichever you prefer.
Okay, great. Thank you so much.
You're welcome. We can't hear you,
Yeah,
Dr.
and
Bird.
I see patients
there
in
you go.
Medford, Pittman, and Vineland.
Okay.
Got me? I see patients in Medford, Pittman, and Vineland, so whatever office is easiest for you.
Medford would be, yeah, I'll go ahead and set that up. All right, well, thank you so
I'm there on
much.
Thursdays. Unfortunately, you missed me today, but I'll be there.
I'll set that
All
up
right,
through
thank
your
you. I
office.
appreciate it.
Have a good evening. Thank you, doctor.
Thank you. Was there
Okay.
anybody else tonight?
Yes. What are your thoughts on orthovisc injections?
So orthovisc injections are part of an injectable option for what we call viscosupplementation. So basically what those injections are is an element of normal joint fluid that isn't as healthy when there's inflammation and specifically arthritis. Those are really meant to treat arthritis. They're not specifically meant to treat meniscus tears. There are a subset of patients that have arthritis and have developed what we call degenerative meniscus tears. But the orthovisc or any of these other viscosupplementation injections are really meant to treat the arthritis component of that. And they've been shown to work really well in about 30% of people. And we think that there are people who are responders, and there's something about their physiology that makes them that gives them a good, strong response to those injections. And then there's a group of people that are non-responders, probably another 30%. And then there's some people in the middle that get a variable response. But the people that get a really good response, those 30% of responders, it's pretty obvious within the first 2 to 3 weeks of those injections starting that they respond well. But the real indication for those is arthritis.
Thank you, Dr. Bernardini. Was there anybody else tonight? All right, well, if there's no other questions tonight, I'd like to thank everybody for joining us tonight. Dr. Bernardini, thank you again for your time tonight.
Thank you.
All right, everybody have a good evening.
All right, bye.
Thank you.